I'd like to thank Innovasis and Brent and Amy for hosting another great event. I'm going to paint some broad strokes regarding some principles in adult deformity, and then Justin and Jeremy will follow and give you some more specifics regarding alignment and prevention of complications. Whether you're a minimally invasive spine surgeon or a moderately invasive spine surgeon or a maximally invasive spine surgeon, you still have to adhere to the principles of surgical treatment. So we know that spinal deformity in the adult is an increasingly common disorder with significant and measurable impact on health. And despite advances in techniques and surgical skills, the surgical treatment is still complex with significant risk of complications. Adult spinal deformity is basically a malalignment of the spine, and it can be segmental, regional, global, or, as typically the case, a combination. Spinal alignment is critical for maintenance of an upright posture, protection of the neural elements, stability of the axial skeleton, and minimal muscular energy expenditure, as exemplified by the cone of economy conceptualized by Dubussé. Adult spinal deformity includes scoliosis, sagittal malalignment, kyphosis, spondylolisthesis, and axial plane deformity. Scoliosis can be the sequelae of childhood deformity, or it can arise de novo through the degenerative disease. Other causes of adult spinal deformity include trauma, tumor, infection, inflammatory conditions, and the all-important post-surgical or iatrogenic deformity. And the iatrogenic deformity is a result of either destabilization or malalignment. The prevalence of adult spinal deformity has been reported to be as high as 32% in the general population and up to 68% in people over age 65. And with U.S. population growth, the number of older adults with adult spinal deformity is estimated to be more than 60 million by 2050. So with an aging population, with more comorbidities, and increasing numbers of people with adult spinal deformity, it's going to place an ever-growing strain on our healthcare resources. So it's important that we develop evidence-based approaches. If we don't, policymakers and payers are going to. So first of all, should we be treating adult spinal deformity surgically? You know, there was a time way back when it was, all the experts said it's too dangerous. You do not need to be treating this stuff surgically at all. Well, we know that adult spinal deformity has a measurable effect on physical and mental health, with back pain, neurologic symptoms, difficulty standing upright, and functional limitations, and can result in a marked disability when compared to the general population. And the disability is on par with such disease states as diabetes, heart disease, and cancer. And furthermore, the impact of adult spinal deformity worsens with age. And we know now that the operative treatment of adult spinal deformity can result in improved function and health status with reduced pain. And furthermore, the elderly gain a disproportionately greater improvement in disability and pain despite a higher complication rate. Essentially, they start out worse, but certainly have a higher risk. The indications for surgery in adult spinal deformity are not as clear-cut as they are, for example, adolescent idiopathic scoliosis, which is typically related to curve magnitude and or progression, whereas in the adults, they seek care more often for pain and disability due to degenerative disease and malalignment, and the curve magnitude may not be the major issue. Other differences between adult spinal deformity and the adolescent deformity are more frequent comorbidities, issues with bone quality, stiffness, sagittal malalignment, the frequent need for neurologic decompression, and these patients often require fusion to the sacrum. So there's a wide variability in the indications, surgical techniques, and postoperative care, and SIG has written and talked about this quite a bit. It's very difficult to develop appropriate use criteria and still be responsive to these variables. For example, this is a 56-year-old physician who had adolescent idiopathic scoliosis as a child. She's had gradual, painful progression, and after following her for several years, elected to proceed with surgical treatment. She's healthy, she exercises regularly, she's a non-smoker, no narcotics. Ideal patient that you'd like to see. And she's now 5 years out from this surgical procedure. She had no surgical complications. She's having minimal discomfort and working full-time as a pediatric oncologist. On the other hand, here's another patient, 70-year-old lady with severe back pain, bilateral lower extremity pain. She's had progression of her deformity. She has severe stenosis on her other imaging studies. Comorbidities include osteopenia, hypertension. She's deconditioned and likes her hydrocodone. So this is not an ideal patient to operate on. She has a totally different risk profile than the first, and so our goal here is to try to optimize the patient, get her as close to that other patient as you can before even considering anything surgical. So this patient was put on a year course of Forteo. She was put on a daily walking program, also started on some Pilates-based therapy, and was gradually weaned from her narcotics. And so here she is now, a year post-op. She's having moderate back pain, no lower extremity symptoms. She still would like to have her hydrocodone, but we're working on weaning that off. So the principle here is surgical indications and goals may not always be the same for every patient with adult spinal deformity. Surgical indications vary depending on risk stratification, patient expectations and desires, as well as a shared decision-making process. And we could spend a whole conference talking about these issues, particularly the risk stratification. But here's an example. This is a patient with back and lower extremity pain, no relief with therapy and injections. And after extensive discussions, she elected to proceed with basically the full scoliosis operation. And she's now 3 years post-op, has some upper thoracic pain, and no lower extremity symptoms, overall happy and working as a teacher. Here's a similar patient, 65-year-old lady. Her primary complaint is right lower extremity pain, has relatively mild back pain, and after discussing options with her, she really doesn't want a big scoliosis operation. She would just like to get rid of her leg pain, which results from her foraminal stenosis at the fractional curve. And so we just elected to do a localized, basically a T-lift, posterior lateral fusion. She's a year and a half out now and is happy. She has no leg pain. She understands that she's at risk for junctional pathology, but after discussing those options, she's certainly willing to take that risk and avoid a big operation. I'm sorry?
What did you tell her about her scoliosis and what you needed to do?
Yeah, we discussed the fact that because of her scoliosis and the obliquity of her proximal junctional level, that she's at higher risk for junctional disease, and she was willing to take that risk. And she may ultimately require a big scoliosis operation. So just a quick word about non-operative treatment, which includes all these things here. Unfortunately, even though we all do it, and we have our individual patients that that benefit from some of these non-operative measures, as a whole, patients with adult spinal deformity, there's really no evidence for improvement or long-term improvement in their health-related quality of life. Yet all these things account for the largest component of increased cost over the past decade. So again, we need evidence-based pathways to justify the resources utilized for these non-operative treatments. Excuse me. So let's talk about some specific indications. Very few adults seek surgical treatment for isolated thoracic curves. Typically, if they do, they're younger adults with significant curves and have concern for self-image, and they're a little bit more like the adolescent scoliosis. So we know that thoracic curves over 50 degrees tend to progress over time, and so if you have a patient with a thoracic curve over 50 degrees who's symptomatic or concerned about their self-image, then it would be reasonable to consider surgical treatment. On the other hand, if the symptoms are manageable, they can certainly be observed for progression. Selective thoracic fusion can be performed in the adult in selected patients. These are typically younger without significant lumbar pathology. Here's an example, 47-year-old female with thoracic curves, some thoracic back pain. Her thoracic curves been gradually progressive, and she was treated with a selective fusion and has done well with that. The majority of patients seeking care for adult spinal deformity have either lumbar or thoracolumbar curves. And so, in general, surgery is indicated for progressive curves, curves that result in severe back and or lower extremity symptoms which have been unresponsive to non-operative treatment, any patient with neurologic involvements, and symptomatic sagittal imbalance. Here's an example. This patient, 58-year-old female with 3 prior lumbar surgeries, including an L5-S1 fusion, severe stenosis at the junctional level at L4-5. She's had extensive treatment with therapy, injections, and medications. So she's now 2 years post-op here with, after having T-lifts and posterolateral fusions at the 2 junctional levels and then an instrumented fusion to T8. You could argue that maybe we should have gone a little bit higher, but overall she's held up. She has no lower extremity symptoms, mild to moderate back pain, and has gotten off her narcotics. Here's a patient with progressive curves, back pain, and left lower extremity pain, who's a year out with, she has moderate interscapular pain, which I see fairly frequently in the patients that have their fusion extended up into the upper thoracic area. She has mild back pain, but no lower extremity symptoms. Most adults with symptomatic lumbar and thoracolumbar curves have lumbosacral pathology, and at least in my opinion, most require fusion to the sacrum. In selected patients, it can be avoided if you have younger patients with healthy L4-5 and L5-S1 segments. I think you're at very high risk for distal junctional pathology if you fuse to L5, and certainly seems to have seen a little bit more of that, particularly with some of the minimally invasive techniques. But at least in my experience, you're at very high risk for having junctional disease if you stop at L5. So the goals of surgical treatment are reduction of pain and disability, safety, and cost effectiveness. How do we reduce pain and disability? Well, first of all, you restore alignment. You decompress the neural elements as needed, and you maintain alignment. And you maintain alignment by obtaining a stable fixation, a solid fusion, and avoiding junctional pathology. We know that there's a direct correlation between radiographic parameters and self-reported pain and disability, and of those, the sagittal alignment is by far the most important. Overall alignment should be harmonious, with lumbar lordosis proportional to pelvic incidence, thoracic kyphosis proportional to lumbar lordosis, and overall global alignment as measured with the SVA or TPA. Patient safety is extremely important, and it's intertwined with every aspect of adult deformity surgery, including patient selection, preoperative optimization, surgical planning, surgical technique and skills, postoperative care, and management of complications. Here's an example to illustrate that point. This is a patient that presented just like this. She had scoliosis in his childhood, but had really never had any treatment, didn't even go to the doctor, then started having some issues with back pain. But her biggest problem was pain where her ribs were impinging in her pelvis, which we see on these severe curves. And she was also starting to complain of occasional shortness of breath. So you look at this and you go, okay, vertebral resections, multiple osteotomies, big deal. But after reviewing it and discussing it with her, and we decided to just treat her this way. She was treated with posterior instrumented fusion, excuse me, from T2 to the sacrum. No osteotomies. Now, I do facetectomies, but I don't consider those osteotomies. And we lengthened her trunk by 6.5 centimeters. She's now 2 years out and is pleased with this result. And I think this was done fairly safely as compared to those procedures where we do the vertebral resections or multiple resection type osteotomies. Cost effectiveness is important, and there's a wide disparity in the cost of surgical treatment depending on location and surgeon preferences, particularly as applies to implant use and the use of biologics and those sorts of things. So how do we help control costs? Well, proper patient selection and optimization, prudent use of implants and biologics, and avoiding complications, particularly unplanned trips to the operating room, which is a big driver of costs. So in conclusion, adult spinal deformity has a significant impact on health. The prevalence of adult deformity will continue to increase. We know that surgical treatment improves health-related quality of life, but there's a wide variability in surgical indications. There's a direct correlation between radiographic parameters and self-reported pain and disability, with sagittal alignment being the most important. And the current economics are not sustainable. Thank you.